Hey everyone, welcome back to our channel, that is Pharmacy Made Easy. Today we are diving into one of the most essential topic and the important branch in the pharmacology, that is pharmacokinetics, or I like to call it as what the body does to the drug. And by the end of this video, you will understand how drugs are absorbed, distributed, metabolized and excreted. Everything is interlinked, so stay tuned and do not skip the video. So first one, what is pharmacokinetics? Pharmacokinetics is the science of how the body processes a drug from the moment it is taken to the moment it is eliminated. It's made up of 4 key steps, that is absorption, distribution, metabolism and excretion, also called as ADME process. So as soon as you listen the word term pharmacokinetics, these 4 absorption, distribution, metabolism and excretion should come into the mind. Each of these steps are interconnected, one leads into the next, and understanding the whole chain is crucial. So let's break it down step by step. Coming to the first thing is absorption. The definition of absorption is movement of a drug from its sites of administration into the bloodstream. In our previous videos, we covered different routes of drug administration, their uses and disadvantages. I'll pin that video below if you'd like to review it. So now here, the key point about the absorption is lipid solubility, which plays a major role. The more lipid soluble drugs is, the easier it passes through the membranes. Biological membranes, that is, and cell membranes. So quick tip here is non-ionized drugs or lipid soluble, so there will be easily absorbed through the cell membranes. The ionized form of a drugs or water soluble, so there will be poorly absorbed. So as this is water soluble, we try to eliminate through the kidneys. And the other factor that affects the absorption is ionization and the pH. The absorption of a drug also depends upon its medium. It's in the acidic or if it is in the basic, and how it affects the ionization. An acidic drug like an aspirin is absorbed well in the acidic stomach, while a basic drugs like a morphine is absorbed better in the basic medium, which is in the intestine. But here is a twist. Most drugs can switch the forms. In acidic environments like the stomachs, acid drugs stay non-ionized and absorb well. In the basic environment like the intestine, the basic drug gets absorbed better. So match the medium to the drug and absorption wins. Now we talked about absorption. Let's talk about the bioavailability, which is directly connected. Definition of a bioavailability is, it is a fraction of an administered dose of a drug that reaches the systemic circulation. Higher the bioavailability, the lower the dose needed, and the lower the bioavailability, the higher the dose needed. So what are the factors that affects the bioavailability? The first factor that affecting the bioavailability is absorption. If the drug is absorbed more, the bioavailability is more, obviously. If the drug absorption is less, the availability is also less. So the other factor that affecting the absorption is the first pass metabolism. This is also called as pre-systemic metabolism. The drug absorbed via GI tract go to the liver before entering the circulation. If the liver metabolizes too much, that'll be decreasing the bioavailability of a drug. For example, let's take a nitroglycerin. It has an very high first pass metabolism. That's why it is given sublingually to skip the liver, act quickly and be self-administered in the emergency conditions like heart failures. And remember, IV drugs have 100% bioavailability because they are directly injected into the bloodstream through the intravenous route. Alright, so the drug has been absorbed, it enters into the bloodstream. What now? Next comes the distribution. Distribution is how drug travel through the body and reaches the target tissue where it can work. Coming to the definition of then distribution, it is a process of reversible transfer of a drug from the blood to various tissues and the organs of the body. So think of a bloodstream like a delivery van. Once the drug is inside, it gets delivered to the different neighborhoods like the brain, liver, muscle and the fat. So what are the factors that affecting the distribution? The first one is blood flow to the tissues. Higher perfusion organs like a brain, heart, liver, kidneys receives a drug faster when compared to the low perfusion areas like a fat, skin, muscle. So another factor that affecting the distribution is capillary permeability. Organs like the brain have the tight junctions. We call them as in blood-brain barriers. These organs and the organs like a liver are more porous, so the drug will be entering easily. Coming to the other factor that affecting the distribution is plasma binding, plasma protein binding. The drug bind to the albumin here. If there is a more drug bind to the protein, that is an albumin in the blood, that will be inactive. The free drug is active, which reaches the organs and show the pharmacological response. For example, the warfarin is 99% protein bound, only 1% is active. The other factor that affecting the distribution is the lipid solubility. The lipid soluble drugs crosses the membranes and the barriers easily. They can even accumulate in the fat or enter the brain. And the next factor here is the volume of distribution. So formula for the volume of distribution is amount of the drug in the body by plasma drug concentration. So here we can interpret by this value, volume of distribution is the low over the VD, volume of distribution, the drug stays in the blood. Example, heparin. Higher the volume of distribution, drug goes deep into the tissues. Example, chloroquine. So there is another case here. There is a special case, that is redistribution. The lipid soluble drugs like thiopentol reaches the brain very faster, but then redistribute into the fats and muscles as well. So the effect wears off quickly. This is why thiopentol is used in the short procedures like anesthesia induction. So fast in is fast out. So coming to the next thing, metabolism. Definition of metabolism is the biotransformation of a drug, usually in the liver, to prepare it for the excretion. So fate of the metabolism. Once a drug is absorbed and distributed, it undergoes a biotransformation, also called as metabolism. Usually this happens in the liver, and depending upon the drug, this metabolite can lead into 3 different outcomes. The first one is active drug become inactive. This is the most common route. The drug enters into the body, does its job, and then metabolize, shut it down. Example, lidocaine gets broken down into an inactive component eliminated through the kidneys. And there is other examples like propanolol, a beta blocker, becomes inactive after this metabolism and it will be excreted through the kidneys. Even the ibuprofen, the common painkiller, is inactivated after doing its job. Coming to the second part, the active drug remains active even after the metabolism. This means the drug and its metabolites both keep working. Here are few of the examples. Diazepam turns into desmethyl-diazepam and finally oxazepam. All the metabolites that are mentioned will be active. Coming to the second example, here is a codeine becomes morphine. That's when its real analgesic power kicks in. Coming to the next example, the carbamazepine used in the epilepsy turns into an active metabolite too. And the imipramine and antidepressants become desimipramine, which also works. Coming to the third pathway, inactive drug becomes active. These are called prodrugs. These are designed to be activated by the metabolism. Example includes levodopa becomes dopamine, crucial in the treating Parkinson's disease. The second example for this is enalapril, an AC inhibitor used in the hypertension management, turns into an active form called enalaprilat. And this other example is anti-cancer drugs like cyclophosphamide becomes phosphoramide mustard to attack the cancer cells. And the final example that is clopidogrel used to prevent the strokes and heart attacks need activation to work. So to wrap it up, some drugs get inactivated, some stays active, and other also get to the work after metabolism. This is why knowing a drug metabolic phase is crucial, especially for dosing and predicting the effects. If this helps clarifying the things, Give it a thumbs up and share it with your fellows, med buddies, and hit the bell so you don't miss the next part in the pharmacology playlist. So depending upon the drug design, metabolism can either deactivate and keep it active or activate it completely. Metabolism occurs in the two phases. In the phase 1, it adds the liver adds or unmasks a functional group via oxidation, reduction, or hydrolysis. And second phase of the metabolism, it conjugates with something like glucuronic acid to make it water soluble so that it can be easily eliminated or excreted. Only after the both phases, the drug is ready to be excreted. Enzymes involved in the metabolism there are two types. One is microsomal enzymes in the liver and like endoplasmic reticulum, inducible or inhibitable. And there is another type of enzymes or non-microsomal enzymes which will be outside the endoplasmic reticulum, not affected by the inducers or inhibitors. For example, warfarin is metabolized by microsomal enzymes, whereas heparin is metabolized by non-microsomal enzymes. So here the enzyme can act as an inhibitor or inductor. If the drugs like rifampicin, an enzyme inducer, is taken with the warfarin, the liver enzyme increases, more metabolism happens, warfarin level drops. So dose need to be increased. On the other hand, if the cimetidine, an enzyme inhibitor, is taken, metabolism slows, so warfarin accumulates, so dose should be decreased. Note, heparin is unaffected because it uses a non-microsomal enzymes. So easy mnemonics of enzyme inducers are GPRS cell phone, means griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and phenobarbital. These acts as enzyme inducers. So coming to the enzyme inhibitors, let's see the mnemonic, that is Vicks phase, that is valproate, isoniazid, cimetidine, ketoconazole, erythromycin, and ciprofloxacin. That wraps up the metabolism. Next up, we'll explore the excretion. Now, drugs finally leave the body. Excretion is a final drug elimination step. What is elimination? Elimination is metabolism plus excretion. Once a drug is absorbed, distributed, and metabolized, it must be eliminated from the body to prevent accumulation and toxicity. So the major routes of excretion are renal route, this is the primary route, and second one is a biliary excretion and or enterocephalic circulation, and the third one is the lungs for the volatile substances. The fourth one can be through the sweat and saliva. This is the minor route, and few drugs will be eliminated through the feces and few with the breast milk, folks. Now let's tackle the final chapter of the pharmacokinetics, that is excretion, or simply put, how the drug exits the body. First one is the glomerular filtration. Glomerular filtration occurs in the kidneys. Once the free unbounded drug can be filtered, not the one stuck with the plasma protein. So drugs with the higher protein binding got the less filtration. Quick facts is normal GFR is around 125 milliliter per minute. That's 180 to 250 liters filtered every day. But only about 2 liters of urine is produced. Yep, the kidneys are efficient. So coming to the next one, the tubular reabsorption. Now comes tubular reabsorption, and here where the drug can get sneaky and try to re-enter the bloodstream. About 99% of the filtrate is reabsorbed. Remember this rule, lipid soluble drugs are easily reabsorbed. Water soluble or ionized drugs are more likely to be excreted, and it's all about pH dependent. If the drug's pH match with the urine, it stays non-ionized and get reabsorbed. If the pH is different, it becomes ionized, get trapped, and boom, excreted. The clinical trick here is forced diuresis in poisoning. Let's say someone overdoses. How can we help the body get rid of the drug faster? Example, if the individual is poisoned with an aspirin, which is an acidic drug, the strategy is here to alkalize the urine with NaHCO3. If the individual is poisoned with a basic drugs like an amphetamine, acidify the urine with the NH4Cl. So coming to the other step during in the excretion through the kidneys is tubular secretion. Next, tubular secretion is an active process in the proximal tubule, and it can even separate the protein bound drugs. It is a saturable process, meaning if overloaded, it slows down. Here is a classic example. Penicillin is secreted actively, but when given with the probenecid, secretion is blocked, keeping the penicillin in the system longer and show its effects. So what are the factors affecting the renal excretion? A few more things that affect the renal excretion is kidney function like GFR, glomerular filtration rate, or creatinine clearance. And the other thing is urine pH, which influences the reabsorption as well. And the third factor that influences urine trapping is a cool concept. We use pH manipulation to keep a drug ionized so it cannot be reabsorbed and excreted faster. So coming to the other route of excretion of a drug is biliary excretion and enterohepatic circulation. Some drugs don't go through the kidneys. Instead, they go through the bile, enters the intestine and get reabsorbed. This is called hepatic circulation. This process can be delayed, elimination, and they prolong the drug action. Examples include rifampicin, oral contraceptives, and morphine. Now here, a clinical insignificant. If you take antibiotics like rifampicin with an oral contraceptives, it can break this cycle and lead the contraceptive failure. Yep, always important to counsel the patient. Coming to the next thing, that is a lung excretion. Volatile drugs like an anesthetics, isoflurane, nitrous oxide, they are inhaled through the lungs. So no liver, no kidney, just in and out. That's why they have fast onset and the offset. So, and the other minor routes of excretion are, there are through the sweat and saliva. And yes, even the breast milk. The drugs like tetracyclines and the chloramphenicol can show up in the milk, which can be risky for the infant. Always double check if the drug is safe during the breastfeeding. Key pharmacokinetic formulas are below. Before we wrap up, here are the few key formulas every student should know. Here, coming to the rate of elimination, the formula for the rate of elimination is drug eliminated by the time taken. And coming to the next thing, that is clearance. Clearance is equal to rate of elimination by plasma concentration. This is golden standard for dosing. Next formula is for the half-life, T-half. T-half is equal to 0.693 into volume of distribution by creatinine clearance. This helps the plan the dosing frequency. So coming to the kinetics of the drug elimination, most drugs follow the first order kinetics. So what is first order kinetics? A constant fraction of a drug is eliminated per time. The half-life and the clearance stay constant. But in zero-order kinetics, enzymes are saturated. A constant amount of drug is eliminated regardless of the concentration. So the half-life increases with the dose. Few examples for the zero-order kinetics are warfarin, alcohol, theophylline, and phenytoin. And the other clinical insight is half-life and the clearance. Let's recap. Half-life is how long it takes for a drug level to drop by 50%. Affects by both metabolism and excretion. The clearance tells us how much plasma is cleared per time from kidneys, liver, or both. So high clearance is equal to shorter half-life, so more frequent drug dosing is required. So final wrap-up for this ADME is absorption. It is how it enters the bloodstream, and the second one is the distribution, how it spreads throughout the body, and the third one is a metabolism, how it gets transformed, and the fourth one is an excretion, how it leaves the body. Together they form pharmacokinetics, the science that helps to understand drug action, dosing, toxicity, and even the interactions. If you found this video helpful, hit the like button, subscribe, and let's know which topic would you like to see next. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.